Hi guys, welcome back. So this marks the sixth and for now the final video in our series on antibiotics. I hope it's been informative, and as always, please leave any comments below if there's any particular class you'd like me to make a video on, or if you have any more questions, please leave them below and I'll get back to you. To wrap this whole kind of topic up, I think it's important that we discuss which antibiotics to use when. Now, obviously, a lot of this comes during your clinical years and things like that, and I'm only an MD1, so I actually don't know most of the scenarios in which you prescribe antibiotics, but there are a few key principles. So, often you'll treat based on, there will be guidelines within your city, your region, based on antimicrobial resistance and the patterns of resistance in that area. Oh, not resistances, resistance. So, based on the way a patient's presenting, you're probably going to have a few differential diagnoses in your head. And based on those, you need to, in order to give empirical therapy, you need to have an idea of what kind of resistance patterns are going around that area. So, for example, if you have a male presenting with a pussy, purulent discharge from the urethra, and you know that they've had a history of unprotected sex, you're probably thinking gonorrhea. But gonorrhea is getting extensively resistant to antibiotics. And so in order to treat this patient quickly, you need to have a good idea of what it's likely to be susceptible in your area. So that's one thing. The other thing is, again, based on the clinical scenario, you're going to have an idea of whether it's going to be of a few different causes. You need to think about whether it's gram positive or gram negative. And we've discussed this in some of the other videos. Some of the drugs have difficulty getting through either the peptidoglycan layer or the outer membrane. They also might act on specific pathways. So, for example, drugs acting more on the cell wall are going to probably be more effective in a gram positive than gram negative. So that's something else to keep in common. Different bacteria as well can lead you down different pathways in terms of treatment. So, for example, Pseudomonas aeruginosa has a very is intrinsic to so many antibiotics that if you're thinking Pseudomonas while you're waiting for culture, your empirical therapy is going to have to be a very specific type of antibiotic. I think we're using carbapenem at the moment for that. So there are a few of the principles. There is another set of principles as well that we need to keep in mind. I mentioned this in the first video, I think, about bacteriostatics and bactericidals. Often when we're treating empirically, we're giving a few different antibiotics in order to cover a broad range of potential diagnoses. And we need to be careful of this because in some cases, those antibiotics are going to react to have a positive effect, and in other cases, a negative effect. So as well as all the the clinical features of your patient and any of, you need to make sure that the drugs that you're giving aren't going to compound any illnesses they currently have, any comorbidities. You also need to make sure that there's not going to be drug interaction. And I really like these graphs. These kind of give you a good idea of basically the four different outcomes you can have. So additive means that if you give antibiotic A and antibiotic B together, the effect that you get is just the same as adding the effect of A and the effect of B together. So that's pretty simple. Indifferent means that A plus B is pretty much the same as A and B. It doesn't really have any effect. It's basically just the increased concentration of something, more so than anything else. Antagonistic's what we're worried about. That's where we're going to have, we're giving drug A or drug B is going to be significantly better than giving drug A and B together. So the example of this is a bacteriostatic versus bactericidal. And I'm going to go into all these in a bit more detail in a second. This is just an overview. And then synergistic is this one here. This is where when you combine A and B together, you get a significant increase in the effect that's well above just the effect of A and B to kind of individually. And so you can see the difference here between synergistic and additive. So So yeah, let's start with synergy then. So synergy is when A and B together give a better result than the effect of the better result than the effect of A plus the effect of B. This can often happen by either blocking sequential steps of a metabolic pathway. So blocking sequential steps of a metabolic pathway. This is usually additive, but in some cases it can enhance the killing. So the example we have is sulfonamide with trimethoprim. They both act on folic acid synthesis, but in different steps of that pathway, and they're particularly effective in protozoal parasites. The other way it can happen is they can inhibit enzymatic degradation. And I have already given an example of this. That's what happens in the case of amoxiclav or augmentin, where you give a beta-lactam with clavulanic acid. Clavulanic acid inhibits the beta-lactamase and allows the beta-lactam that it's coupled with to be much more effective than it otherwise would be. The third way that we can get synergism is by enhancing the antibiotic uptake by the cell, by the bacteria. So an example of this is a beta-lactam with an aminoglycoside. So we know now that aminoglycosides work in the ribosome, and in order to have a really strong effect, they need to be able to get into the cytosol to bind that ribosome. And we also know that those aminoglycosides are often susceptible to efflux and prevention of and they actively pumped out of the cytosol. So if we couple it with a beta-lactam, the beta-lactam can break down the cell wall and allow the aminoglycoside in to bind to that ribosome. Cool. Then let's talk about antagonism. Antagonism is when the efficacy is worse together than separate. So A plus B is worse than A alone or B alone. And again, the common example of this is inhibition of the bactericidal activity of an antibiotic by adding in a bacteriostatic. Most bactericidals require actively replicating bacteria, whereas bacteriostatics, their mechanism of action is they slow down bacterial replication so that the immune system can take over. So obviously if we put them together, they're going to really poorly affect each other. So with the example is if we do tetracycline, so for example, doxycycline is a tetracycline. If we combine that with penicillin G in meningitis, that can have disastrous effects. So we didn't touch them. Tetracyclines, though, they inhibit protein synthesis, so they're similar to aminoglycosides, but they act in a slightly different way, so that instead of being bactericidal, they're bacteriostatic. They simply slow down protein synthesis rather than resulting in the accumulation of proteins. So by combining that tetracycline, such as doxycycline, with penicillin, which is a bactericidal, you can get this antagonistic effect. So let's say here, bactericidal versus bacteriostatic, cidal versus static. That's one. The other one is we can get induction of enzyme degradation, so induced enzymes. So different enzymes are different, have the ability to induce different kinds of enzymes that will, degrade the antibiotic. So, for example, some beta-lactams are very weak inducers of beta-lactamase, and so they work very well. But then as soon as you combine it with another drug, another broad spectrum, for example, it can very strongly induce a beta-lactamase, which is going to knock out both of those beta-lactams that you've been using. Another way is through competition for the same target. So if they're both binding to the same receptor per se, or the same enzyme, then trying to add both is just going to make, they're both going to compete for the same thing and neither of them are going to do as good a job. And then we can also, it can also happen through inhibition of target. So the example of this is actually, we talk about in a fungus. So polyene is an antifungal that binds to sterile and fungal cell membranes. Imidazole is a drug that interferes with sterile synthesis. So if we add them both together, the imidazole is actually going to antagonize the polyene because it's going to remove the sterols that the polyene binds to, and therefore you're not going to see a good effect. We can kind of summarize these kind of tables here with this concept of Jowett's laws, and I hope I said that right. Jowett's laws. Oh, not Jaws, laws. So that is a bacteriostatic versus a bacteriostatic will usually be additive. Can't spell today. Additive or indifferent. However, if we put a bacteriostatic with a bactericidal, that's usually antagonistic. So we need to be really careful of that in a clinical scenario, especially something like meningitis, where rapid treatment is really, really important and we can't afford any mistakes, such as combining two drugs that are going to be antagonistic to each other. The last one is if we have a bactericidal and a bactericidal, and a lot of the time those are synergistic. Great. And so that's it for today's video. As always, if you've got any questions, please leave them below in the comments. But if not, thanks for watching.